Now, these discriminatory belief systems, we think, have the potential to fade. These are values. And these values have waxed and waned over the history of this country. And we think that there has been improvement. There have been, values of equity, values of fairness, values of equality that have essentially influenced institutional decision-making. However, institutions, both in their overt policies and their practices, still take the path of least resistance, unless they're challenged by organized and activated community members, particularly those that are most impacted by the decisions. So we think part of the practice is holding institutions accountable, including public health departments and planning departments. Next slide. Again, everybody knows what this is, and the question always is, could this happen in my community? This is Katrina. And don't ask the question. It can happen. Next slide. This is the Midwest. I don't know if Cleveland was involved in this, but this was the major heat wave in the mid-90s. And an analysis of who died, who was disproportionately affected by this, shows you that the Katrina population, elderly, African American, socially isolated, living in low-income communities, disproportionately on an order of 5-10 times the odds ratio, died from that heat wave. Next slide. One author said in describing this heat wave, the heat wave was a particle accelerator for the city. It sped up and made visible the hazardous social conditions that are always present but difficult to perceive. As I drove through East Cleveland yesterday, I was shown the hazardous social conditions in this county. Yes, the weather was extreme, but the deep sources of the tragedy were the everyday disasters that the city tolerates, takes for granted, or is officially forgotten. This is the invisible made visible. These hazardous social conditions basically allow you to predict who will live and who will die. Regardless of whatever the insult or the threat is to the community, whether it be pandemic influenza, HIV/AIDS, the foreclosure crisis, you name it, you can predict who's going to be disproportionately impacted because of these hazardous social conditions. And they are invisible for most people because we don't look at our history and we don't look in aggregate at how these things like health are being distributed across populations. And it's important for public health and others to make the invisible visible to people and then to direct strategies and policies that are intentionally designed and explicitly designed to change the status quo. Next slide. Okay, so now Alameda County at one time, we have this sort of life expectancy hierarchy. High life expectancy, high measures of social status. Put it again. Intermediate life expectancy, intermediate measures of social status. It's not really intermediate, it's just sort of not quite as high. Next. And then low life expectancy, low measures of social attainment, and we spend hundreds of millions of dollars on individual services in these communities every year, and then don't analyze the impact over time as to whether we're actually making things better. Hit it again. We know that in these red communities, the schools are not producing readers at a minimum. Next. We know that jobs are difficult to find, high demand, low control, low income, don't pay a living wage. Next slide. Crime is rampant, and many of these communities are policed like war zones. Next slide. We know that they're racially and economically segregated, both historically and through present-day practices. Next slide. We know that housing is difficult to afford and low quality, lead-filled, full of mold. Next slide. And we know that point sources of toxicity are preferentially cited in these neighborhoods. Next slide. And then we asked this kid to pull himself up by his bootstraps. And my question to you, my challenge really to you is, what do we owe this kid? Our children. What do we owe this kid? A brochure? What is the practice that we are going to be able to bring to life that actually makes real our promise to eliminate health disparities? I think that this meeting today is an example of that practice. It's got to be a real commitment. It can't just be a bunch of, oh, isn't that too bad? Ain't it awful? Which typically we do at a pretty high expense, I would put it to you, though. We spend a lot of money saying, ain't it awful? We don't spend a lot of money redesigning what we do to actually try to achieve what we claim we're trying to achieve. We don't. We really don't, and the data would support it. Next slide. So we have this model that we think is not a recipe for essentially cold fusion. This is just simply a framework to help people in public health and outside of public health understand where we need to try to intervene to try to change the status quo, to change the outcomes of the current system. Hit it one time. Health disparities in the NIH live down there. This is where things exist. We just, we have no idea how they were created, we just have to deal with them. And that's important. It's important to deal with them. I say when you walk into a community and there are fires burning, the first thing you do is put out the fires. But if you come back the next day and there are fires burning again, at least ask yourself, why are fires burning in this place again? Before you put them out again. And think about how can we prevent these inevitable fires from burning. Do it again. And that's the world of health inequities. Health inequities are not about individuals, not about individual behavior, which is not to say that individual behavior is unimportant. It's to say that individual behavior has to be contextualized. In unnatural causes, they make the point of the choices we make are the choices we have. And if your choices are constrained, you're not going to be able to make those healthy choices as easily. And we're talking about odds. Everybody has an anecdote about, oh, my grandmother grew up in the poorest neighborhood and had no access to healthy food, was ducking bullets every day, and now she's the president of Xerox. And if she can do it, anybody can do it. And it's like, yeah, sure, but what are the odds? This is all about odds. And we've created odds in many of our low-income communities that more people will fail, not be able to get over that wall, to take the individual steps that are necessary to protect ourselves in health, because society has conspired against them and created barriers everywhere they turn. Next slide. And again, so we have a practice, and very simply, it's about place. And it's very similar to what Martha described in East Cleveland and elsewhere in Cuyahoga County and in the city of Cleveland, where we're working in partnership with residents. We believe that it's necessary to build social, political, and economic power in these communities, organize people, resource them, and defer to their priorities, not our priorities. This isn't about us telling them that you need to smoke less and drink less. It's about them telling us, because we're their health department, what they need us to do, and then working in partnership with communities to try to achieve that. We also think that we have to deal with policies and institutions and the behavior of institutions like health departments, like planning agencies, like other governmental bodies, and we have to hold them more accountable. We have to use the data that we have to look at the health impacts of non-health policies and make the case and advocate for changes in policies that have adverse health impacts, like education policy, like land use policy. And finally, we have to address the values. What are we about? I mean, is Bill Gates right that this practice is offensive to our values and an insult to who we are? And if so, how do we respond to that? Like I said, Bill Gates has called us out. Are we just going to sit here? Next slide. Okay, one time. Don't believe me. Read for yourself. The World Health Organization has put this all together in a beautiful monograph called Solid Facts. Do it again. So has the MacArthur Research Network looked at the American story, the American data that justifies the social inequities as being drivers of health inequities that ultimately drive health disparities. Next slide.